Okay, welcome everybody. I think we'll just give it 30 seconds to allow people in and then we'll get going. Thank you. Okay, partly in the interest of time, we'll kick off. Welcome to those of you that are already with us. I'm sure others will join along the way. Yeah, so I just want to welcome you and thank you for joining today, this webinar. Today is World Suicide Prevention Day 2025. This webinar is entitled Staying Safe Together, a spotlight on communities and practical resources. And I'll come back and talk a little bit about why we chose that title in a few minutes. Just firstly, though, to just talk very briefly about the three organizations that have put this together. As you can see, their logos on the slide before us. So the first is Grassroots Suicide Prevention. They're based in Brighton, charity of about 20 years in existence, but based in Brighton, but working across the UK. And they're dedicated to empowering people to help save lives from suicide. Rethink Mental Illness, another charity I'm sure probably familiar to most people are on this webinar. Been around for I think 50 years from my research. And they work to improve the lives of people that are severely affected by mental illness. And then to UOK, which is actually a network that provides a range of community-based mental health and well-being support services to adults in Brighton and Hove particularly, but also the wider East Sussex area. And these resources range from well-being groups, money advice, one-to-ones, suicide prevention training, and they're all actually completely available free of charge. So that's always handy. And we will be highlighting and signposting resources as we go along. So maybe then just to tell you a little bit about myself, just very briefly. So my name is Richard Tandoh. I'm happy to be here today to be chairing. So my job as the chair is to sort of top and tail this and to keep us moving into time. We only have an hour together, which is quite short given all of the rich content we've got for you, but my job is to make sure we get through it. Maybe just a word as to why I do this. So I actually spend my days doing a mixture of being an independent technology consultant and a teacher, but I do have lived experience of mental health issues. And this is pretty much my give back. I'm a Rethink expert by experience and also a peer trainer at the West London NHS Wellbeing and Recovery College. And I do that as a give back because when I needed help, I got it from these organizations. And I feel it's only right then to give something back in order to help others as well. So then to this seminar, I said the title is Staying Safe Together. Why are we doing this seminar? Why have we chosen this title? So we're actually been prompted by a new set of guidance that was produced by NHS England earlier this year in April, which was called Staying Safe from Suicide, Best Practice Guidance for Safety Assessment, Formulation and Management. And it's freely available to access online. I've been through it. We will share it as one of the resources. And what it's about is recommendations to sort of change the way that risk assessment, what was risk assessment around suicide has been done to date, which is sort of a stratified model we'll probably mostly be familiar with, the sort of low, medium, high risk categories, to one that's actually about safety planning and much more centered on an individual. And a lot of I think the driver behind this has actually been a personal story by an individual, Philip Perry. I've heard him talk. You can Google, and he's done interviews publicly as well. And he lost his son to suicide, and actually the day before he had been actually categorized as low risk, and so that led him on a journey to try and understand why that would have been the case. And actually, what has been determined is that every day in the UK, 17 people die from suicide. 5 of those are in contact with mental health services, and 4 of them, so 80%, have actually been assessed as low or no risk. So it sort of led to an investigation that has shown that the current way of doing things isn't really working. So what we want to do here is showcase how these organizations are moving forward, taking the guidance and putting in place the sort of safety planning approach to this, moving away from the sort of risk assessment. So just finally then to some logistics. So we will share the slides and the recording afterwards. There won't be time for questions during the webinar, but if you put your questions into the chat, we will come back to them afterwards. Like I say, we'll be sharing the recording, the slides and links to resources. Gemma, my colleague and one of the speakers, will also be in the chat in case anybody needs any help. But just to say, we appreciate, this is a very heavy topic and one that could be personal to a lot of us on the call. So please do look after yourself as we go through this. So, okay, so that's just to welcome you. So then to our first set of presenters. So we have 3 presenters for you from Rethink Mental Illness. The first is Lord Colclough. She is the head of suicide prevention. She has a background in counselling and psychotherapy, and amongst the things that she's done at Rethink has been a pioneering suicide prevention program in partnership with the North West London ICB, which actually won an award last year for mental health partnership with the NHS at the SSJ Partnership Awards. I know Lord's well because I serve as an expert by experience under her. Her colleague Gemma is a service manager also at Rethink. She's a dedicated advocate for suicide prevention and postvention, driven by a personal experience and commitment. And then Wendy Robinson is also a service manager at Rethink, working in the Brighton area for the last 11 or so years, particularly in SOS and Mendos. So I will turn it over to Lords for the first presentation. Thank you.
Thank you, Richard. And I just wanted to start by setting the context a little bit and just positioning voluntary sector organisations as really well placed to work within these new government guidelines. I'd argue that we've actually been working like this for decades. Often the work we do is empathic, timely, because we have that time to build relationships and dynamic. You'll hear from Wendy and Gemma a little bit later, get some more detail and really hear about that relational safety model, where at the core of suicide prevention is the building of trust and hope. And with that as well are the partnerships that we have. So we work very closely with the councils, Surrey Council and Brighton and Hove, and with the NHS and IAP services, as well as the other voluntary sector groups. There is a space within the voluntary sector, I think, and safety planning for genuine depth in connections and relationships. And all our staff at Rethink Mental Illness on our services bereaved by suicide, they've all experienced suicide bereavement themselves. So when they're safety planning, it will always be about real life and not clinical risk necessarily. So our services and others, often with it, you'll hear of other speakers a bit later on, and we can stay connected when systems can't. And I think what is key with the voluntary sector is we can see people who feel unseen, who often we will be the first port of call for them, whether it's a faith leader, whether it's a leader of a football club, or it's a trusted service like one of those you're going to hear about later. And that's where we can engage with people earlier, we can stay longer, because often we're not constrained to medical models or care pathways. You're going to hear about some life-saving work we do, which really does complement the systems we work within. And I'm now going to hand over to Gemma, who's going to talk about our safety models.
Thank you. Cheers. So we know that people who are bereaved by suicide are far more likely to experience their own suicidal thoughts and ideation. And so planning around a service user's safety is paramount across all of our services. And we use safety plans frequently. I think we need to question the likelihood of somebody searching through their emails for their plan whilst potentially being distressed or feeling quite frightened. And we often find that our service users don't actually want to co-produce a safety plan. They may feel too overwhelmed or just feel like they don't want one. So what we try to do is we focus on the fundamentals of the safety plan during our support sessions. So things like recognising triggers and identifying ways to keep safe are areas we focus on throughout. Revisiting these areas can help with self-awareness and really help to embed some of those coping strategies without having to sit down and do a formal plan, which will be lost in an inbox somewhere. So in addition to our safety plans, we've also introduced a collaborative approach to safety planning. And with the service user's permission, we can involve a trusted person. So this can be anybody that's trusted by our service user. So it doesn't have to be a next of kin. It could be a neighbour, a friend, or it can be a family member, anybody who is trusted. And what this means is that we can plan and co-produce a safety plan. And if the service user needs support, there is already a kind of alert system, if you like, in place. So it might be a code word, it might be a text, it can be anything that is comfortable to our service user, which will alert their trusted person, who can then action any agreed steps within the plan. So it's really trying to add as many layers of safety and support to our service users going forward in their support. And I will hand over to Wendy.
Thank you, Gemma. I'm going to spend a bit of time on this this slide. We're going to look in the next 4 minutes in these 4 points, but I want you to look at the pictures. And I welcome this opportunity from the guidelines to review what we're already doing as a service and organisation. And also it's an opportunity to evaluate with those who use the service and expert by experience that what we're doing and what we're offering is in line with what's being recommended. We're very fortunate with our service that we are able to give people something that a lot of services are time constrained to. We're allowed to give people time. So when people become more well, or they are doing better or more out of crisis, we are able to see over a period of 3 to 6 months whether that is sustainable, whether they are regaining their control back, whether they're going back to work, whether they're feeling more well, whether they're recognizing earlier what their pre-triggers are. So I think these words, even if you forget everything else that I'm going to say today, if you think about these 5 words, I think it covers the guidelines. It also covers what we try to do in the service, though we are reviewing everything. So it's about giving someone time and really listening, and also making sure that you give plenty of time for that. And I think there is a skill about asking particular questions that open up an opportunity for someone to kind of evaluate what's going on for them right now and what's worked for them and what's not. And the likelihood, often you can kind of try and give a lot of advice about numbers you can call, but I think the real skill is, who are they likely to call? What service are they likely to call? What friend? What partner? Have they got anyone that they can do? What were their previous experiences when they called? When did they call? Like I always say, if you have a sore tooth, we might go like this for a little while. A few days have gone past and then it's really bad. And that's when we phone for an appointment. What we do is try and have someone call at the point that they're just beginning to feel like things are changing, things are, they're isolating themselves, they can feel that things aren't feeling right. And it's about giving yourself as much time as possible. And then what we're looking to do as a service when perhaps the near crisis has passed, or they feel like things are turning around, is that we keep people on. We might see them less. We might see them every 2 weeks now, or every 3 weeks, or monthly. But what we're trying to see is whether they feel that that it's sustainable, and also that they feel more in control of what's going on and when to call for help. So to the next slide, please. So approaching our safety plan, who is the form for? The safety planning is both continual and central, and not necessarily just the form. The form might change daily. They might have, but basically it's their form. It's not our question exercise for us. It's very important to have key questions that will elicit information as to whether you need to look at action right now, or whether there can be some protective factors in place, like they might have another service that's also supporting them, or they're trying to go to work, or so forth. Our current form, as Lords and Gemma have indicated, is under review as an organisation, and also our service. Currently, we do not have too many questions, and we feel this was deliberate because it encourages discussion and control. But we do encourage our expert by experience to give us feedback about those forms. Next. So the link between community support and clinical pathways. Well, we know very well that each service has their own criteria and has to follow their own assessments according to their commissioning. But prevention is about asking support and identifying pre-triggers earlier, so that you can get the support around you at an earlier point. But then services also have to decide whether they're prevention services. So if someone phones up, are they only going to get support when they're in crisis, or are they going to have that support earlier? And I think Brighton and Hove particularly have looked at, as particularly from now on, health forums in each catchment areas for the public to go and suggest ways of improving services in their area, to look at that as well. And I encourage the public and services to attend these health forums across the city. I think it's about keeping it simple and discussion based as well, and the likelihood that the person is going to make it relevant to their life about who they ask for support. Okay, next slide.
Wendy, I'm going to just ask you to leave it here, just in the interest of time, but we will share the slides, so the example, people can have a look at it. I think we're sharing the form as well.
Thank you.
So thank you very much. So thank you very much to that team for giving us a sense for how they're doing safety planning, clearly much more about the person and sort of a whole person focus. So thank you for that. So now I'm going to invite Alex Harvey to speak to us. He's from Grassroots Suicide Prevention. He's the head of partnerships and innovation there. He's been there since 2010, and as a part of his role, he's overseen a number of innovative programs and projects, including the Stay Live app, Firsthand, and the Real Talk interactive film. So over to you, Alex.
Thanks so much, Richard. So I will skip over this first slide. If you could go to the next one, Brooke. Just, you've given a kind introduction there, Richard. So if you go back to the session outline, thank you. So today we're going to be looking at neurodiversity and suicide prevention. So looking at some of the particular challenges that neurodivergent people may face around suicide, and some of the practical adjustments that we can make in supporting them. We're going to hear some insights from our lived experience group. Also going to introduce the neurodiversity hub that Grassroots has developed and is being launched today, as well as the enhanced safety plan on the Stay Alive app, which is also being launched today. So if we go on to the next slide, what is neurodiversity? So when we talk about neurodiversity, we're talking about a natural diversity in how human brains are wired and how people think, learn, and experience the world. It's an umbrella term that includes autism, ADHD, dyslexia, dyspraxia, Tourette's, and many other ways of experiencing the world. The key point really is that neurodivergence is a difference, it's not a deficit, and these ways of thinking bring real strengths as well as challenges, and the challenges are actually often coming from how society is structured, not from the person themselves. So neurodiversity reminds us that there's no kind of single normal brain as such. We all bring our own ways of thinking and experiencing. Next slide, please. So why does this matter in relation to suicide? So I'm sharing a range of different statistics here focused on autistic individuals and ADHD and the heightened risk around suicide. There's been a lot of different studies around this. We know there is a heightened risk. But what I've put in bold and I've underlined here is that really important fact that risk is linked to unmet needs, stigma and systemic barriers, not neurodivergence itself as such. It's interesting, it's only in the 2023 to 2028 national strategy that autistic people were included as a specific demographic in that kind of suicide prevention policy for the first time, despite knowing that there have been heightened risk for a long time. And if we go to the next slide, this is just a quote from Sally Polanski at the Amaze, a brilliant charity working in Sussex around neurodiversity, who've supported the Neurodiversity Hub. And I think this quote just captures the fact that the systemic barriers that people who are neurodivergent may face in accessing mental health support, and how that barrier is so important to address. If we go to the next slide. So today, we only got 15 minutes. It's not a lot of time. I'm going to focus particularly on the autistic experience and ADHD and their links to suicide. So just giving a kind of very top level kind of overview of some of the risks and challenges, and also how we can make practical adjustments. I'd really recommend people to look at the Neurodiversity Hub, which is going to be shared in a link later, which go into a lot more detail around all these issues. So for an autistic individual, the first point I wanted to highlight is this idea of camouflaging or masking. This is when an autistic person maybe hides or suppresses their true self in order to fit in socially, and this can be very draining. It can lead to a sense of disconnection from one's true self, and over time that feeling of isolation and despair can really grow, and there's a strong link there to suicide risk. The next point is alexithymia, which means a difficulty in recognizing and describing your own emotions. So for an autistic person, this can mean not realizing when they're in crisis, not actually knowing that, and not having the words to communicate their distress. And this naturally makes help seeking a lot harder, and it can delay getting the support they need when they need it. The next point is repetitive or monotropic thinking. This refers to a very focused and sometimes rigid thought patterns. This can be incredibly helpful and a real strength in terms of creativity and focused work, but when it comes to suicidality, it can really mean that people get stuck, and it's harder to shift those thoughts, which can lead to higher risk. And finally, this point around there being a lack of tailored support. So many mental health services just aren't designed for autistic needs. Environments can be overwhelming, the communication styles used may not be accessible, and clinicians just may misinterpret autistic behaviour. If we go to the next slide, just going to look at some practical adjustments. So very simply using clear, direct language, not using kind of abstract, vague terms, very literal, concrete terms can be really helpful in terms of communication. Allowing extra time for processing. So just because someone's quiet, silent, doesn't mean they're not engaging. It may mean they're just taking longer to process what's going on. Thinking about the environment, sensory overwhelm can be a real factor. So just reducing noise, thinking about bringing someone into a calmer space if needed. Offering choices. So for instance, offering to go for a walk or sit down, giving someone that sense of control can really help to reduce anxiety. And looking at alternative communication methods is also really helpful. Someone might prefer writing, texting, visuals rather than just speaking about what they're going through. And then finally, collaborative safety planning, which has already been mentioned, and is a key factor in all of this. And we'll touch on that a little bit later. And so I'm just going to share an excerpt from a podcast that is on the Neurodiversity Hub. This is Emily, who's one of our brilliant lived experience experts, talking about her experiences.
I don't think we're hearing it. Can we just start it?
I could hear that fine, Richard, so I don't know about anyone else, but okay.
Okay.
Yeah, I think others have been nodding, so let's carry on. So thank you so much to Emily for sharing those insights. Next, we're just going to have a quick look at ADHD experience around suicide. So similar, going to go through some of the challenges and then some of the practical adjustments. So impulsivity can be a key factor. People with ADHD may be more likely to act quickly or on intense thoughts or feelings. And in the context of suicide, that can increase risk. Emotional dysregulation is another factor that people with ADHD might experience, meaning that when despair or shame or anger hit, they can really intensify very quickly and escalate into suicidal risk. And then rejection sensitivity is another factor. Just a sense of when they feel they experience rejection or criticism, failure very strongly. And this can trigger feelings of worthlessness or hopelessness, which have strong links to suicide. And then also co-occurring difficulties, things like higher rates of depression, anxiety, and substance use can also compound that risk. If we go to the next slide, looking at practical adjustments around this, things like keeping communication very focused, structure and routine, allowing movement, fidgeting, pacing can be very helpful when things that you maybe would be aware of anyway, but just allow someone to kind of to be themselves. Validating emotions is very important. Simply acknowledging the way someone's feeling can really help de-escalate the situation. And finally, as mentioned again, safety planning is so fundamental to all the support. We're just going to hear from Molly, another one of our brilliant lived experience experts, talking about her experience. Thank you so much to Molly for sharing that. So I'd really encourage people to have a look at the Neurodiversity Hub. The podcast that those experts is on there in full. It's essentially a free online resource hub. There's information and toolkits for professionals, for families, for neurodivergent people. It's been shaped by lived experience, and it's going to be evolving with ongoing feedback. If you go through the next 2 slides, I've just got a few screenshots of what it looks like, but certainly I'd encourage you to have a look yourselves and explore what's on there. It covers in a lot more detail what I've tried to cover very quickly today. If we go to the next slide, I'm just going to mention very quickly the Stay Alive app, which, as I mentioned, it's a free resource for anyone who's at risk or anyone supporting them, and it brings together a lot of different evidence-based resources on there. The safety plan on Stay Alive is already based on best practice. There's a standard safety plan on there. If we go on to the next slide, I can just cover.
Sorry, Alex. I think unfortunately there was just 10 minutes, not 15. So, but I see the link has been shared, and we will share the slides. And also,
okay.
Sorry for coming in earlier, but some of us, I think, couldn't hear the sound. I think we didn't know we had to actually click it on the slide. But there are links to the podcast in the slides and also on the hub, as you pointed out. So
brilliant. And I would just say one final thing, that the safety plan, we have now added 4 additional questions, which are based on the safety plan for for autistic people developed by Dr. Sarah Cassidy. And I'd really encourage you to take a look, but I appreciate time. So thank you, Richard.
Thank you very much, Alex. Like I said at the top of the session, lots to fit in, but stuff that can be obviously followed up afterwards. So I'm going to move straight to James O'Neill. He's a training officer at Friends, Family and Travellers. He delivers a number of courses, including those on inclusive services. He himself actually comes from an Irish traveller background and has a special interest in human rights. So, James, over to you.
Thank you very much, Richard. And thank you everyone for joining today, and thank you for inviting me to speak. I'm really privileged to be able to come on and say a few words. I know I'm strapped for time, so I'm going to try and squeeze everything in. I know all of the sort of speakers have had the same issue, but what I have done is I've kind of packed my slide deck with probably a few too many slides. But I've done that for the reason that I want, when the session is finished, when you receive the presentation slides, even if I don't have the opportunity to go through them, you will at least have an opportunity to have a look at them yourself, because some of the stuff, of course, is an important topic, and it was, you always don't know how much to include and how much not to include, but hopefully I've included just about enough. And like I say, if not, you will have the opportunity to go back. One more thing also, sorry for whoever's controlling the slides. These slides have got sort of bullet points that appear as you click. So if you click once, it's not going to skip to the next slide. So it's going to be sort of bullet points, which I didn't really plan for. So if you just maybe click that screen 4 times, it should bring up the bullet points. That's it. Perfect. Brilliant. Thank you very much. So just very quickly about FFT, we are a national charity that works on behalf of and in conjunction with all Gypsies, travellers and Roma, regardless of ethnicity, culture or background. We're active in advocacy casework. This is, I suppose, one of the most integral departments within the organisation, always oversubscribed really, with individuals and families reaching out for support. We actually have a hotline telephone number, which I'll include in the sort of additional resources that I send across to Brooke to hopefully share with you. And yeah, it's a hotline telephone number on which community members, Gypsies and travellers can phone, and the members of staff that answer those calls, they could be faced with a very wide variety of issues. It could be in relation to mental health, it could be in relation to an eviction, it could be in relation to criminal justice or domestic abuse. It could be absolutely anything. So a really difficult job being done by the advocacy casework team. Policy and cultural competency training. So as Richard just mentioned there, I deliver inclusive services training sessions. So if you're interested in partaking in one of those, do feel free to drop me an email or check the FFT website. And FFT, we are the secretariat for the all-party parliamentary group on Gypsies, Traveller and Roma. And we are the strategic partner of the Department of Health, NHS England and Public Health England as the Gypsy Roma Traveller Member Organisation of the VCSE Health and Wellbeing Alliance, a bit of a mouthful that one. And finally, we are a registered Royal Society for Public Health Training Centres. So just to give a real brief overview of the organisation, there is of course a whole lot more going on, but just to give you a flavour of the organisation. So next slide, please. And again. Perfect, thank you. So firstly, I just want to briefly speak about social attitudes. You know, for gypsies and travellers, social attitudes towards gypsies and travellers, sorry, are really quite stark, the sort of statistics that we've done research on. And of course, as it says, they're experiencing a lifetime of social exclusion and othering, so to speak, often leads individuals feeling, you know, isolated and having a lack of belonging, a lack of sense of self, and unfortunately lower self-esteem, which of course can then lead to, you know, serious mental health issues. So yeah, in 2023, FFT commissioned YouGov to conduct a survey looking at social attitudes, and there are 3 bullet points that will appear on your screen now. So the top one there, as you can see, 45% of respondents said that they'd be unhappy with a gypsy or a traveller moving in next door to them. You know, bear in mind, many of these individuals may well already live next door to a gypsy or traveller, have a good, decent, you know, positive relationship with that neighbour, but just has, you know, no idea about their background. 38% of respondents said they'd be unhappy with their child meeting up with a gypsy or traveller child in the home, you know, for a play date, as they're called now. And a third, or just over a third, well, actually a third, 33% of respondents would be unhappy with a family member marrying a gypsy or a traveller. And like I say, this is just 2023. This is, you know, fairly recent. There was just over 2,000 individuals took part in this survey, and the one that's going to come up on the next screen as well. So yeah, as you can see, some stark stats there around social exclusion. And if we look at economic exclusion, if we just click 3 times again, you can see some of the statistics that came from that. So it's the same sample size, just over 2,000 individuals took part in this survey. And as you can see on the screen there, 34% of respondents said they'd be uncomfortable having a gypsy or traveller in their home, and that's, you know, either socially or as a tradesperson. 22% of respondents would be uncomfortable employing a gypsy or a traveller, and 34% of respondents would not be comfortable buying a service from a small business if they knew that that business was run by a gypsy or a traveller. And I suppose these particular stats may go some way to explaining the, you know, extraordinarily high levels of self-employment among gypsy traveller communities. I'm pretty sure that gypsies and travellers have the highest levels of self-employment when compared with all other ethnic groups in the UK. And yeah, the impact of both social exclusion or you know, social ostracisation and economic exclusion, the impact on you know, life chances and opportunities, you know, really can't be underestimated. And unfortunately, many individuals, because of this, will you know, will mask and will hide their ethnicity in the workplace. Will you know, I don't know any gypsy or traveller, as Richard mentioned, I'm from Irish traveller background myself, who would voluntarily, you know, sort of put their hand up in the workplace and sort of declare that they are, you know, a gypsy or a traveller. It just wouldn't happen in my experience. And this job that I'm in now with FFT is the very first job that I've ever, you know, felt comfortable enough to actually say, you know, I'm an Irish traveller. And I've had, you know, a lot of jobs in the past, but I will skip on. I'm really, I'm used to delivering like 2-hour sessions, so this 10 minutes is new to me. So I will try and rush through everything, but apologies if it feels like I'm going too fast. So just looking at health inequalities in relation to gypsies and travellers, unfortunately, you know, they're really quite stark, and gypsies and travellers are known to face some of the most severe health inequalities in the UK. There should be a few bullet points if you just click maybe twice. Or not? No? There should, if you click the mouse, there should be bullet points coming up. Are they not coming up? Oh, I can't see them. I don't know if everyone else can see the bullet points. Oh, you can all see the bullet points. Oh, for some reason I can't. Sorry, I don't know why. It's just, all right, fine. I have to just do it from memory. But yeah, gypsies and travellers are known to face some of the most severe health inequalities in the UK. And according to the Census 2021, what were the statistics now? Do you know, I don't know if I'm blimmin' know the statistics off the top of my head. But I do, well, actually, I'll tell you what we could do. We skip to the next slide. It actually shows the statistics on a chart. So we'll go through it that way instead. So that's fine. We go to the next slide. Thank you. Oh, so I can control the slides. Oh, I'm so sorry. I didn't realise I could control the slides. Oh, brilliant. Sorry, apologies. My bad. miscommunication there. So yeah, I'm sorry. Gypsy and travellers, as you probably read on your screen, it weren't on mine, but have life expectancy 7 to 10 years shorter than the general population. This was actually revised recently. It was previously thought to be around 10 to 25 years shorter than the general population, and it's recently been revised. But there are some people that believe this is a bit of an underestimate. And according to the census 2021, gypsies and travellers reported the lowest figures of rating their general health as good or very good, compared to 82% overall. And gypsies and travellers, unfortunately, were twice as likely in that census 2021 to report bad or very bad health. And if you do click on that red census 2021 when you receive the slides, it will take you to the specific gypsy traveller section of that census. And these reports, or these statistics, these poor health stats, were unfortunately reported across all age groups. And this was the slide I just mentioned a moment ago. So this is, I suppose, just a visual representation. You can see some of the stark health statistics there. I won't go through all of them, but I would like to just briefly at least stop on the 6 times more likely to die by suicide. So there was an all-Ireland study which found that Irish traveller women were roughly 6 times more likely to die by suicide, and Irish traveller men were roughly 7 times more likely to die by suicide when compared with the wider population. So as you can see, there's unfortunately some really stark health statistics. I would love to get into all of the, or at least some of the influencing factors which contribute towards these poor health inequalities. Unfortunately, as I've said already, we're obviously strapped for time, but what I have ensured is that in the final slide of this pack, there's links to specific mental health, suicide support and prevention reports that have been published by FFT in relation to gypsies and travellers specifically. So when you do get those slides, as well as sort of being able to read the actual statistics, you'll also be able to research some of the reasons behind those statistics. And some of them are here. I'll just fly through them. Social exclusion and discrimination, as I mentioned a little bit earlier on. Difficulties accessing support, barriers around mistrust of services, and then of course also issues around literacy. There are unfortunately some quite poor levels of literacy among gypsy traveller communities, and there are many different barriers present, unfortunately, which restrict access to support for those gypsies and travellers who are having mental health crises. Unstable living conditions, often certainly those individuals who are travelling and living nomadically and travelling on a fairly regular basis, not being able to stop anywhere for really very long at all because there isn't the infrastructure in place, and often being moved along every time they stop. High unemployment and poverty, unfortunately, as we mentioned a little bit earlier on, and maybe one of the sort of most significant contributing factors is the cultural stigma, certainly with gypsies and travellers. Mental health issues often not openly discussed whatsoever, which of course makes it difficult for individuals to seek help. And yeah, it's very difficult at the moment, the situation. It is improving slowly, but there is still a long way to go. And just on the sort of cultural stigma and around the sort of lack of willingness for people to discuss mental health in gypsy traveller communities, if you are ever working with a gypsy traveller individual and you hear them mention nerves or bad nerves, or my nerves are shot, anything around nerves and bad nerves, essentially that is a gypsy or a traveller speaking about mental health. Many community members would shy away from actually using that phrase mental health, and instead they would refer to maybe nerves or bad nerves. And again, reasons behind that, you can find information in the post session pack, which will get sent across to you. This here is a video. I'm going to skip past it. It's a brilliant video. It's around 20 minutes long. It's called Reaching for the Rope. Please do, if you get a chance, have a quick watch of that. And just some general recommendations while we're here before I go. I know I'm strapped for time, but I'll try and be quick. How long have I got? 1 minute? I've got 60 seconds. 30 seconds, James. Oh, lovely. Okay. Well, all the general recommendations are on your screen there. They've all got hyperlinks, so you can click on them and it will take you to a relevant web page. Just while we're here, the NHS Accessible Information Standard has just recently been revised. Do click on the self-assessment link. It's compulsory for all public services, and it's advised as best practice for others. And it basically takes self-assessment and it will identify ways in which there may be some holes in your service, what you can improve accessibility for individuals with disabilities and learning difficulties and other issues. that is it. I'll leave you there. We do have a mental health webinar, FFT, on the 25th September from 12 to 1. You can click on the hyperlink and it will give you information. And also I've sort of cherry picked some of our most pertinent reports for you to have a look at when you receive the slides as well. So do have a look. Thank you. Apologies. Sorry, it was a little bit all over the place there, but I just wanted to try and squeeze in as much information as possible. And I'm more than happy for Brooke and her colleagues to share my email address with participants of this session. So if there's any questions you have or anything you'd like to discuss, like I say, do feel free to drop me an email, but I'll let Brooke send that out with all of the other bits and bobs. So yeah, thank you everyone for listening, and thank you for inviting me, Brooke.
Thank you very much, James. That was
thank you, Richard.
Very interesting. Good to get an extra dimension there. So then to our last presentation, we're going back to colleagues from Rethink Mental Illness. It's Natasha Sinclair and Bethany Wilson. So they're both locality leads. Natasha in the Criminal Justice Division at Rethink, and Bethany in the Northeast Division. Natasha is a leader in mental health innovation and performance coaching. She has 15 years experience in cultural change and personal transformation across public and private sector. Beth has worked in talking therapies for over 8 years in community IAP services, and she's currently going through her IPT training. So I'm going to pass over to Natasha and Bethany for final 10-minute presentation. Thank you.
Thank you, Richard. So we're just looking at kind of risk and how we manage that at the moment within the prisons. So our main objectives are the presence of risk in prisons, difference between managing risk in the community versus the prison, our specific Rethink risk assessment that we do within the prison setting, how we do our safety planning, and what changes we plan to make. Next slide, please.
So I've just put together some statistics just to help people understand the prevalence of risk in the prison population, but also the importance for our service to make sure we are getting risk support right. Obviously, due to time, I'll let everybody just read that in their own time. However, a stat which I think would be important to mention at this point is evidence does suggest that 1 in 2 people are impacted at some point in their lives by the criminal justice system. So understandably, yes, it is quite a niche service working in the prison, but it's important to consider that actually this impacts everybody. So it's important for everyone to have awareness of this. Next slide, please. So I've just popped down a few factors on why those in prison may have increased risk of self-harm or suicide. So deprived economic social backgrounds, substance misuse, which can often be long-standing, and also experiences of traumatic life events and increased ACEs as well. I guess on top of this, they've also got to contend with the prison environment, which there's no secret, there's a lot of bullying, there can be debt issues, there can also be physical isolation. So a lot of prisoners can be cut off from family support networks. There's also uncertainty about sentencing, parole. So obviously there's increased anxiety within the prison setting. Inconsistent regimes as well. So what we mean by regime is sort of the structure to the day that can change quite rapidly due to kind of staffing and things like that, or if there's an incident in the prison. So a lot of the time, if prisoners have their coping strategies to manage thoughts of self-harm and suicide, which could be, going to work or socializing with someone on association, etc., around the yard, then if that's changed last minute, obviously their coping strategy could be gone. So we've got to be very thorough with our risk planning in case that does happen. But also as well, great exposure to suicide. So, a lot of prisoners are exposed to witnessing suicide and self-harm in the prisons, obviously witnessing violence and things like that. So these are all things which us as a service we have to consider, and it's things which we have witnessed as well. So we already look at that kind of holistic approach to safety planning, but yeah, it's definitely something which we need to be more kind of consistent with and aware of. Next slide, please.
So looking at the difference between the community and the prison, obviously there's quite obvious differences, but I guess mainly that in the community, individuals are independent living, they have minimal supervision, they get support from family, healthcare, crisis teams. So I guess the difference there is often if there are referrals to crisis teams, we don't always get an outcome as to what's happened. But there's diverse protective factors, employment, hobbies, family, and individual freedom as well, going for a walk if needed. So obviously in a prison environment that's not viable, but obviously in the community, if you that's what you needed to do, then you have the ability to do that. So yeah, if we can go to the next slide, please. So again, in the prison environment, there's constant supervision, there's structured routines. We've got a lot of on-site support. So we have, with our mental health team, for example, it's a mental health integrated team. So we have primary and secondary together. The support from chaplaincy, listeners, which is your trusted prisoners who are trained up by Samaritans that support individuals if needed. Safer Custody is a prison-based team that support individuals to obviously help with kind of things around self-harm or checking if they're struggling with anything particular that can increase risk. Our key workers as well are specific officers that each individual prisoner is assigned. So they have quite a few people that they can contact. Obviously, the other issues are that they can potentially be prone to bullying, debt, gang-related issues, substances. There is an increased amount of neurodiversity in the prison environment that obviously can have an impact on risk. We have daily multidisciplinary team meetings to discuss changes in risk if needed. So we have that anyway as standard, but that's also a space where we can kind of share discussion about any concerns we have about specific individuals in relation to their risk. And we also work collaboratively with various services within the prison. So we have our drugs and alcohol recovery team, offender management unit, which is your inside probation, essentially, chaplaincy, gym, and the wider prison. Next slide, please. So this is kind of a condensed version of how we assess risk currently. So we look at kind of obviously suicidal thinking, what their current status is, so any content, triggers, duration, frequency, and any historical data around that as well, whether particular times that were more triggering for them. If they've come from another establishment, we would get a transfer of care in relation to that. And we would also look at key dates. So that's kind of, say someone had like an anniversary coming up, like a relative passed away, and that tended to be a trigger point. We would pass that information on to the Safer Custody team, which I mentioned earlier, and then they can go out and see that individual on that date to check that they're safe. So that's quite a useful thing that we tend to use. Looking at specific intent, kind of rating it on a scale of 0 to 10, just in terms of any sort of intent that they have to do anything to themselves imminently. Are they able to keep themselves safe? Would they be willing to access support that exists within the prison? So we'll look at that more specifically in the safety planning stuff. And we look at that for self-harm, risk to others, which also includes why they're in prison in the first place, and risk from others as well, if they're in debt or if they're getting bullied or getting any hassle. Any treatment history, so in terms of mental health treatment that they've had in the past, any substance misuse that they've had in the past, any current medication, and how that's kind of impacting them. So trying to get a really holistic viewpoint of kind of what's going on for them, and then this is then continually checked throughout their care with the mental health team. Next slide, please.
So I'm not going to go into this too much in detail, just obviously due to time, but it's definitely something worth mentioning. So the prison have something called an ACT document, which is essentially to support and monitor those prisoners who are at risk of self-harm and suicide. So it's basically it's an MDT document, so the mental health team can contribute, update, they can attend reviews where required. In the prison, it also has sort of involvement in this as well. So it's like a collaborative approach, as well as kind of with the professionals. So essentially the prisoner would receive support from the prison, but also other agencies involved in their care at the same time. Again, just due to time, I'm not going to go through it too much. So if you could just skip over this one as well. Yeah, Fab, thank you.
So if we look at safety planning then, so when we kind of work with an individual throughout their sessions, we look at kind of helping them identify what their kind of warning signs are in terms of how they feel and what makes things better or worse, what are their internal coping strategies, what are their social support like, kind of in terms of friends or peers that they have, professionals within the prison. So again, chaplaincy, key workers, officers, Samaritans, friends and family, the ACT document. We've also got a CSIP, which stands for Challenge, Support and Intervention Plan. So that's specifically for individuals that are either a threat to other people or are in debt or at risk, you know, so it's kind of a prison supported document that supports them if they are feeling at risk. So there's quite a few things there that's available for them. And again, it's about whether they're willing to access some of that as well, which is really important. And in addition to that, with secondary care, they also have a risk assessment called a 3-part plan. And if we are working with someone that's also under secondary care, we can add to that and update any risks so that it's a live document that follows them through their journey within the mental health team. Next slide, please.
Yeah, just really quickly, just some of the changes that we plan to make. First of all, I think it's really important that we still recognise all the positive practice that we're currently doing around risk management. However, we do recognise that there's always room for that sort of improvement side of things as well. So first of all, we're going to look at training and upskilling for staff based upon the new guidance, especially around like the culture, the language that needs to be used. But also we're going to look at a co-produced safety plan because the prison is quite a niche environment, it's quite specific. We're going to look to get some prisoner feedback just in terms of what they want, what they think would be helpful, so that it can inform our safety plan moving forward. We're also going to move away from using tools to stratify risks such as PHQ question 9, and we are going to continue to improve to work with the wider prison to ensure risk information is shared. We still do this, we do this really well anyway, but again, it's always room for improvement, and just those little changes, you know, could make a difference based upon the new guidance. So yeah, it's definitely worth recognising what we are already doing, but it's just building upon that as well. And Richard, I think that's us done. And breathe.
Thank you very much, Natasha and Bethany. So just really quickly, just to round off, we'll respect the time. So just the last couple of minutes. So we'll be sharing some resources. I think there's a QR code for you to hold your phone camera up to after this to get the link to resources, but we'll also share them with everybody that registered for this. So just some like calls to action. So please do read the Staying Safe from Suicide guidance that was published earlier this year by NHS England. Go through the resources, the slides. As you can see, we had a lot of content. We didn't necessarily have all the time we needed to get through it, but then that allows you to get more from it afterwards. And like it says here, please start the conversations and start to take action in this movement away from the sort of risk assessment piece to the sort of safety planning. And what we've done here is sort of just present some examples. None of these organizations are necessarily saying they've gotten it all right, but they are trying to make that change. And it is a cultural change, and it is challenging, but then it is about saving lives. And just to reference one thing that Lord said, you know, I think the independent and voluntary sector do play a really key role, because you sometimes, and often actually, I know from my own experience, are there long after the more formal sectors like the NHS have probably had to move on to help other people. So thank you again for joining. Again, we recognize the times we live in, slightly tougher economically and politically. So we encourage you to collaborate with one another, to reach out to the organizations here, and to be innovative in the way that you take forward the guidance that's been published recently. So I just want to say on behalf of Grassroots Suicide Prevention, Rethink Mental Illness, and UOK UOK Brighton and Hove, thank you very much again for joining, and have a good rest of your afternoon. And if anything in here has affected you, please do reach out. I know there are multiple resources that were being shared on the chat during this session, so thank you.